Have you, or maybe someone you know, ever suffered from those just unexplained, unyielding headaches?
Oh, the really relentless ones.
Yeah, exactly. The kind of agonizing pain that just, will not respond to standard medications, no matter how many pills you try or how many doctors you see.
Right, right.
Because usually, well, when we talk about a medical diagnosis, there's this expectation of precision, I guess. Like you break your arm, the x-ray shows a jagged white line.
And the doctor just points at the screen and says, hey, there's the problem.
Exactly. It's a very clean binary process. It's broken or it's not broken.
Yeah.
And I mean, we crave that visibility. We really like our pain to be categorized and neatly charted.
We do. But when you step into the world of chronic head and neck pain, suddenly that x-ray machine is kind of useless.
Totally useless.
Yeah. We're looking at a diagnostic landscape that is just incredibly murky. It leaves patients in the dark for decades, honestly. They end up bouncing between specialists who, just keep up in their prescriptions.
Which brings us to the mission for our deep dive today. We are going to explore this massive, fascinating shift in how we actually understand and treat this kind of pain.
Yeah, it's a real paradigm shift.
It is. We've got this stack of peer-reviewed medical journals, some really detailed anatomical studies, clinical data, and we're unpacking the truth about a condition called occipital neuralgia.
Which is such an important topic because for a long time, the medical community treated almost all severe headaches as purely physiological issues.
Right, like a chemical thing.
Exactly. The prevailing logic was that chronic migraines or tension headaches were caused by, a problem with the brain's internal chemistry, or maybe malfunctioning pain receptors or vascular spasms inside the skull.
But we are looking at what happens when you stop treating a severe headache as some mysterious chemical imbalance, and you start looking at it as an anatomical problem.
All right, a physical structural entrapment of the nervous system.
Like a hardware problem, essentially.
Yes, a hardware problem.
And more importantly, we're looking at how treating this structurally, specifically through a peer-reviewed procedure called occipital nerve decompression surgery, is offering a permanent cure. For patients who were previously told, well, that their pain was completely untreatable.
That they just had to learn to live with it, which is terrible advice.
Right. I mean, for someone suffering from chronic pain right now, listening to this is the kind of information that could literally alter the trajectory of their life.
Absolutely. But to understand why the surgical intervention works, we have to ground everything in the hard anatomical science of the back of the head and the neck. We kind of have to map out that hardware you mentioned.
Okay, yeah, let's visualize that anatomy. If you trace the back of your neck, like right up to the base of your skull, you're dealing with an incredibly dense, complex maze of thick muscles and fascia.
And originating from the spine, specifically the cervical nerve root, there are several sensory nerves that have to somehow navigate through this dense maze, just to, provide feeling to your scalp.
Right. The major players here, according to the sources, are the greater occipital nerve, the lesser occipital nerve, and the third occipital nerve.
Spot on. They start deep in the cervical spine and have to travel upwards and outwards to reach the skin. But the thing is, they do not have a clear, empty highway to travel on.
No, not at all.
No, they have to literally pierce their way through multiple layers of heavy musculature to get to their destination.
It's like, it makes me think of trying to thread a garden hose through a really tight, rocky garden filled with heavy boulders.
That's a great way to picture it.
Because if someone steps on that hose, right, the water stops flowing. But in the human body, if a dense muscle clamps down on one of these peripheral nerves, it doesn't just block a signal. It creates severe, agonizing pain because that nerve is literally being crushed.
It is being crushed. And the medical literature actually points out exactly where these physical choke points occur in the body. It's not just a guess.
Right, they mapped it out.
Yeah, anatomical studies have mapped out 6 potential compression points along the pathway of the greater occipital nerve alone.
6. Just for that one nerve.
Just that one. And there are 4 distinct potential compression points for the third occipital nerve.
So it's multiple places where a single nerve can just get snagged or crushed on its way to the scalp.
Exactly. And these nerves frequently have to pierce directly through the semispinalis muscle and the trapezius muscle. And these are thick, powerful muscles. I mean, they carry the heavy burden of holding up your head and moving your neck every single second of the day.
Right, so they're working hard.
Very hard. So when these muscles get tight, whether that's from poor posture, trauma, maybe repetitive stress, Or if the fascial bands around them thicken over time, they create these natural physical choke points. They act like a literal vice grip on those occipital nerves.
Oh, man. A vice grip. And the symptoms of this vice grip are incredibly distinct in the literature.
Yeah.
It's described as this paroxysmal shooting, like electric or stabbing pain.
Yeah, it's sharp.
It starts right at the base of the skull, and then it radiates forward over the top of the head or around the ears. Or sometimes it manifests as just a constant, unremitting pressure that just never leaves the patient.
And here's the tragedy of it all. Because the pain radiates forward into the face or, behind the eyes, it is constantly misdiagnosed.
As standard migraines, right?
Yeah.
Tension headaches.
Exactly. Patients are told, oh, you just have a lot of stress, and then they're prescribed standard migraine medication, which, it makes total sense when you realize the nerve is under constant physical compression.
Wait, how so?
Well, think about it. If you drop a heavy rock on your toe, taking a systemic antidepressant or a nerve-dulling medication isn't going to actually fix the toe, right?
Right. Yeah, the rock is still there.
Exactly. The pain is coming from a physical impingement.
Okay, so I'm assuming this is where the diagnostic nerve block comes in. Because if a patient is sitting in a doctor's office in agony, and the doctor suspects, hey, the nerve cluster in the back of the neck is physically trapped, they have to prove it, right? Before they just start talking about surgery.
Oh, absolutely. And the diagnostic nerve block is the absolute gold standard for diagnosing occipital neuralgia. It is highly, highly revealing.
How's it work?
So a doctor uses a needle, often guided by an ultrasound to ensure microscopic precision, and they inject a mixture of a local anesthetic and steroids directly into the specific pathway of that trapped nerve.
It's basically like flipping the breaker switch to a house then.
Yes.
Like if you flood that specific rocky patch of the garden with numbing fluid and the lights immediately go out, meaning the headache disappears, you know exactly which wire is faulty.
That's a perfect analogy. By bathing the targeted nerves in this mixture, they temporarily shut off all the pain signals traveling up that specific pathway.
Wow.
Yeah, so if a patient who has had a severe headache for, say, 10 years suddenly feels complete relief within 5 minutes of the injection, the diagnosis is confirmed beyond a shadow of a doubt. We now know exactly which anatomical structure is causing the problem.
Okay, but wait. If my decades of blinding pain vanish after a quick injection of steroids or even like a targeted Botox injection, I'm immediately canceling any plans for surgery.
Most people would.
Right. Why wouldn't a patient just go back to the clinic every 3 or 4 months for a top-up injection and just avoid the scalpel entirely?
It is absolutely the most common reaction patients have when they experience that initial relief. But to understand why chronic injections are not a viable long-term strategy, we have to firmly differentiate between treating the physiology of pain and treating the anatomy of pain.
Because daily medications like those tricyclic antidepressants or antiepileptics that neurologists hand out, they are treating the physiology. They enter the bloodstream to try to, turn down the volume on the brain's internal pain receptors.
Exactly. They attempt to make the central nervous system just ignore the alarm bells ringing in the periphery, but they do nothing to remove the physical pressure that's causing the alarm to ring in the first place.
Right. And what about the injections?
Now, as for the injections, steroids reduce inflammation, which can temporarily shrink swollen tissue surrounding the nerve, and Botox can temporarily paralyze and relax the specific muscles that are clamping down on the nerve.
Okay, so they buy you time, essentially, but they don't remodel the landscape.
That's it. Neither steroids nor Botox can remove a tight, unyielding fascial band that has just thickened and grown over the nerve like a strap. Furthermore, they definitely cannot fix a situation where an artery is physically wrapped around the nerve.
An artery?
Yeah. In many severe cases of occipital neuralgia, the occipital artery is actually pulsating right against the nerve.
Oh, wow. So every single time the heart beats, the artery expands and physically hammers against the nerve bundle.
Yeah. Yes. It's literally throbbing against it. And no chemical, no steroid, and no muscle paralyzer is going to magically move an artery or dissolve a thick band of fascia.
Yeah, that makes sense.
Once the temporary chemical effect wears off, the structural trap is still there, just waiting. Therefore, the relief from injections is almost always temporary. And over time, repeated steroid injections can actually degrade the surrounding tissue.
Yikes. So if chemical fixes are just temporary Band-Aids, because the root cause is a structural trap, then the only true permanent solution must be a structural intervention. You have to physically remove the boulders from the garden hose.
Precisely. Which brings us to occipital nerve decompression.
This procedure, from what we're looking at, it's a profound shift in thinking. The goal is to physically free the occipital nerves from their anatomical traps.
It really is. And the source material extensively highlights the work of several pioneers in this field. We really should look closely at Dr. Adam Lowenstein.
Okay. Yeah.
He's a plastic surgeon and a widely recognized expert in nerve decompression surgery.
Now that's interesting. A plastic surgeon taking on severe neurological headaches is kind of a wild crossover.
Yeah.
You would usually assume you need a neurosurgeon for something involving cranial nerves, right?
You would think so, but plastic surgeons are actually uniquely positioned for this. They are deeply trained in the microscopic, superficial anatomy of the face, head, and neck.
Ah, okay.
Their entire specialty revolves around navigating the exact delicate layers of muscle, fascia, and subcutaneous tissue where these specific entrapments occur. But what is particularly compelling about Dr. Lowenstein's work is that his expertise was born out of his own suffering.
Really?
Yeah, he dealt with severe, debilitating migraines himself for 20 years.
Wow. Having a surgeon who intimately understands the absolute desperation of chronic pain, that changes the dynamic completely. I mean, they aren't just looking at a chart, they actually know what it feels like to lose days of your life to a dark room.
Exactly, and his approach heavily emphasizes treating the anatomy of the pain. So, utilizing both Botox for precise diagnostic confirmation and temporary relief, and then ultimately moving to decompression surgery to provide a permanent anatomical fix once the physiological treatments fail.
Okay, but we need to look at the hard data, though. Does this, microscopic plumbing work actually cure the headaches?
The surgical evidence is incredibly robust. One of the specific clinical studies in our sources tracked 232 patients who underwent minimally invasive decompression surgery for occipital migraine trigger sites.
That's a good sample size.
And these were not mild cases. These were patients who had failed multiple preventative medications and were essentially out of conventional medical options.
232 patients at the absolute end of their rope.
Yeah.
So what happened after they recovered?
After a mean follow-up period of 20 months, the patients reported a 94% positive surgical outcome.
Wait, 94%?
94%.
A 94% success rate in the world of chronic treatment-resistant pain is just almost unheard of. Usually, like, clinical trials for new migraine medications are popping champagne if they get a 30% reduction in symptom days.
I know, it is a staggering
Wild.
number.
So what exactly is the surgeon doing once they make the incision? What does the surgery actually look like?
Well, it is highly meticulous, microscopic work. The surgeons make small incisions at the back of the head or neck, often hidden right in the hairline so you don't even see a scar.
Oh, nice.
Yeah. And they go in and carefully dissect the tissue to isolate the exact nerve that the diagnostic block originally identified. Once they find the nerve, they trace its path looking for those specific pinch points we talked about. They physically excise thick bands of connective tissue. They will carefully release and separate sections of the semispinalis muscle that are literally strangling the nerve.
So they were essentially carving out a safe, unobstructed tunnel for the nerve to pass through.
Exactly. And in cases where they find the occipital artery pulsing against the nerve, they will dissect the nerve away from the artery. Sometimes they're coagulating or ligating small, unnecessary branches of the artery so it can no longer act like a hammer hitting the nerve with every single heartbeat.
Just imagine waking up in the recovery room after 5, 10, maybe 20 years of daily, blinding agony. You've been told it's just stress. You've been fed handfuls of pills that make you groggy and disconnected. You've felt entirely hopeless. And then you wake up, and the physical kink in the hose has just been untangled.
It's life-changing. The unremitting pressure at the base of your skull is just gone. It completely restores a patient's quality of life.
That's incredible.
It really is.
It really shows how the field of peripheral nerve surgery is constantly evolving. Like, they're catching the patients who traditionally fall through the cracks of chronic pain management.
Absolutely.
And this specific mechanical understanding of pain ties into a broader, really vital concept introduced in the source literature, the headache spectrum.
Right, the headache spectrum. This helps us conceptualize why some people respond to a single medication while others require complex decompression surgery. Headaches basically exist on a wide continuum.
Okay.
On one far end of the spectrum, you have purely central issues. These are headaches originating entirely inside the brain and central nervous system. Think of a classic episodic migraine with visual auras or a hormonally triggered migraine.
So a completely internal neurological event where a trapped nerve in the neck has absolutely nothing to do with it.
Exactly. But on the other far end of the spectrum, you have purely peripheral issues. These originate entirely outside the skull in the physical anatomy. Occipital neuralgia is the textbook example of a purely peripheral headache. It is an anatomical trap in the neck causing the pain.
But human biology is rarely that neat and tidy, right? I'm assuming most chronic sufferers do not sit cleanly on one extreme end of that spectrum.
No, they don't. Many unlucky patients sit right in the murky middle. They might have a genetic predisposition to central migraines, meaning their central nervous system is highly reactive, but they also have a trapped occipital nerve in their neck.
So that trapped peripheral nerve acts as a constant mechanical trigger that sets off the central migraine.
Yes.
Okay, so the trapped nerve is like a faulty car alarm constantly blaring out in the driveway. And the central migraine is the exhausted homeowner inside the house, finally losing their mind from the noise.
I love that analogy.
You basically have to shut off the alarm outside to have any hope of calming down the house inside.
And that is exactly what we see reflected in the clinical data. When surgeons perform decompression surgery and cure the peripheral triggers by physically freeing those occipital nerves, they completely remove that constant bombardment of pain signals entering the brain.
So the brain is no longer being aggressively provoked every second of the day.
Right. Curing the anatomical issue on the outside of the skull powerfully calms down the entire neurological system on the inside. Patients might still occasionally get a mild central migraine if the weather shifts drastically or, their hormones change, but the unremitting daily agony caused by the trapped nerves is entirely eliminated.
It really demands a total shift in how we approach pain management. We have covered a massive amount of ground in this deep dive.
We really have.
We started with the realization that some of the most stubborn, frequently misdiagnosed head and neck pain isn't just a mysterious chemical imbalance. It's a highly specific physical entrapment. Occipital neuralgia occurs when the occipital nerves get crushed by tight muscles and fascia at the base of the skull.
While systemic medications blindly try to mask the pain and steroids and Botox provide excellent diagnostic clues and, temporary relief, they ultimately fail to fix the physical trap.
Right, because the trap is still there. But peer-reviewed nerve decompression surgery offers a permanent anatomical cure by physically going in and untangling those nerves. It is a scientifically validated lifeline. It's just amazing. It leaves you with a deeply provocative question to ponder as we wrap up today's deep dive. If decades of debilitating, mysterious head pain, the kind that ruins careers and destroys a person's quality of life, can actually be cured by simply untangling a trapped nerve in the back of the neck.
It makes you wonder.
Right. How many other invisible chronic illnesses or mysterious body pains are we currently treating with heavy, mind-altering medications, when the real culprit is just a microscopic anatomical trap quietly waiting to be discovered by a clever surgeon?
It definitely forces you to wonder how much of modern medicine is still just waiting for us to stop looking at the chemistry and start looking a little closer at the anatomy.
Absolutely. Well, thank you for joining us for this deep dive. Keep questioning the world around you. Always advocate for your own health, and we will see you next time.